to be to this meeting. Thanks for the invitation. I've been asked to give you my tips and tricks and tools. So, like Metzger said, you need someone helping you who knows how to use their tools. And this is sort of my Swiss Army knife, how to do uh, CLTI below the knee. This is not specifically a data talk. Speaking proctor, it's not germane to this talk. This is the outline. I think we should probably axe anatomy because I see Dr. Lee follows me with an anatomy section. We look at the definition of CLTI. It's the inability to supply the metabolic need to heal wounds, ulceration, gangrene, etc. And if you are a complete wound healing therapist, you need to pay attention to certain things. These people die. Mortality is related to the cardiovascular, as we know, and stroke events that they have. And so even though you're an interventionalist, please do not forget Jeff Olin's talk yesterday morning. You are responsible for this as well as the primary care physicians. So just because you're an interventionalist and you're at this interventional meeting, you have to do these things because risk factor modification in this diffusely atherosclerotic population of patients is what saves lives, not fixing these limbs. The scope of the problem is roughly 150,000 amputations performed annually. You can also use part definitions and realize that those definitions need to be a little more rigid pressure reductions with ischemic rest pain as opposed to the tissue loss patients. So our goal of CTLI intervention is to restore pulsatile flow to the foot and straight inline flow to the pedal arch. And I don't know any good data to support how many of those vessels that we need to go to that, just like Dr. Saab talked about. Now, if we talk about the angiosome principle, it's a three-dimensional block of tissue that includes the subq tissue, the fascia, the muscle, the bone, fed by a single source artery. There's three of those, the ATA, PTA, and PA. Angiosome, as we know. And you have to also understand and realize all of these connections between these angiosomes. And you have to also realize that in this vascular bed, collaterals become diseased and atherosclerotic, as well as the native vessels below the knee for some reason. And if anybody has a good answer to why, they can certainly tell me because I don't know that. So the angiosome concept, I think, is less important when you have rest versus tissue loss issues. Tissue loss that's above the ankle, superficial ulceration. Diabetics have better collaterals than non-diabetics, typically vice versa in the coronary bed. I also don't understand atherosclerosis enough to know the answer to that. And a fully intact pedal arch, it may be less important for angiosomes. I told you this is not a data talk, but I could show you data to demonstrate direct versus indirect angiosome revascularization, where there's improved healing and there's reduction from amputation if you do direct versus indirect. But I could also show you this paper published a couple of weeks ago by a group out of Russia demonstrating whether you propensity or non-propensity match angiosome revascularization, that it makes absolutely no difference for amputation-free survival or male. So it failed to support angiosome revascularization. I think if blood goes there, you should too. And if you can revascularize it, you revascularize what you can to improve blood flow to the foot. You will help something. Now, I'm not going to talk about anatomy because I'm not stealing Dr. Lee's talk. I didn't realize, my apologies, that you until I looked at the schedule today. But the next is I want to tell you how I choose microcatheters and wires. And I want to give you a little tidbits on that. So I have this dartboard in my office. I throw a dart at it, and whatever it hits, that's where I start. So that's probably what you feel like starting out doing this, but not really. What I think you need to do is understand the basics and the principles, understand your equipment, your efficiency and escalation of the equipment, the different properties of it. Be safe, keep it simple, stupid. You have to reduce your variability. And you have to be cognizant of cost, please. I'm 60 years old and I've paid taxes for a long time. You can spend $600 on a guide wire. Please don't go to a synchronous wire to start with. We use that a lot in the head, but I don't suggest you use it to try to find collaterals in the leg unless you fail more cheaper devices. And a microcatheter, my favorite, is an over-the-wire balloon. Kill two birds with one stone, but you can spend $1,000 a pop on these fancy microcatheters that you see. So if I had my perfect guide wire wish list, I would have a pushable, torqueable, trackable, radiopaque guide wire that's kink resistant with an atraumatic tip and that has no friction in a microcatheter. But in reality, you all know that doesn't exist and there's no substitute. Sahil Parikh mentioned this earlier. You have to have your feeler gauge and your feeler wire that you use to determine if your visual and imaging characteristics that you know before you go into this case or during this case matches with how these vessels feel. You can feel a lot, but you have to have a feeler gauge and you have to first have your workhorse wire. And realize that if you have a workhorse wire, as you increase the tactile feedback, you reduce the lubricity in what this wire will actually do. So these two don't go hand in hand. So if I look at workhorse wires, you need to have a low tip load. You need to have a linear torque, easily shapeable, inexpensive. My favorites are BMWs and run-throughs, but you should probably pick two. You don't need mine. You need use the ones that are in your lab and the ones that are your wires that your lab uses, etc., or whoever you get your best pricing from. So there's several wire crossing techniques. There's the micro channel crossing technique, the drilling technique, cap penetration, and the J-loop entry. So we look at direct penetration wires. We need wires that have a progressive tip load with torsional rigidity. If we look at the microchannel crossing wires, we need those that maybe have a smaller lumen, have increased lubricity, such as, say, a Fielder XT, which is my favorite with a 0.09 lumen. And most polymer jacketed wires work well for crossing microchannels. You don't have to grab a synchros wire for $600 just to cross that. A knuckling wire needs to have a good column strength. It needs to have lubricity so that you can prolapse it and snowplow it through plaque. And externalization wires, you can take a piece of wire off of the fence and use that. You just need a long wire. Pick a couple that you use. You don't have to use mine. So a typical approach I would use for a CTO, and I do coronary CTO work as well, which I know a lot of you do in here. But I would take my feeler gauge initially, and I would determine what characteristics my lesion or my cap, etc., had for whatever direction. I may escalate up to a pilot 50, a few tip load increasing graduations of Miracle Brothers, and then I might finish off with a harpoon to try to get through a distal cap. But what you need to remember is do not take forever. And if you have no self-control and you're stubborn and you have an ego, set a timer. You use several minutes, whatever you want. Pick 5 minutes, set a timer. Don't take forever or you will fail and you will expose yourself to tons of photons. The other characteristics you need to understand are that how microcatheters affect your tip strengthness of your wires. As you advance or retract your microcatheter, you can increase or decrease the tip strength of your wires. You need to use that to your advantage, not to your disadvantage, which some people do. So you want to use the most direct access as possible. You need to become familiar with your toolbox of wires, not mine, and you need to combine the properties of a support catheter to your advantage, not to your disadvantage. And if you have no self-control, you have to use a timer to control yourself. So final thoughts, these are suggestions, not rules. Analyze your modes of failure, limit your inventory, and categorize your wires into the task-specific tools, such as I have done in these previous few slides. A little bit about pedal access, and I know this is probably overlapping a lot with other people's talks. This is the new rodeo in town. It's a paradigm shift from what we've typically done in the past, and that's mainly because of the 20 to 30% failure rate that we have with antegrade crossing of lesions. And Dr. Saab talked about the anatomy of lesions well there. Alternatives for this access below is morbid obesity, hostile groins, failed antegrade approach, which is inevitable, flush total occlusions, and multi-level disease in your trifurcation below your knee. Of utmost importance is you have to have dual, as you've seen Jose Wiley do, not Jose, but Metzger did, dual digital subtraction imaging to completely identify what you're dealing with, where you're going and where you're not going. The use of a ruler, agree 100%. For the micropuncture technique, you can use either a flow switch or you can use a hemostatic valve. I typically prefer, I don't do a lot of intervention from the tibial. I do occasionally, but I typically like to flip it over to antegrade. So I only use dilators, or I use the micropuncture sheath and just hook a hemostatic valve to it for that. I use copious amounts of nitroglycerin as well. For the ultrasound guided technique, I think the hockey stick probe is of utmost importance, mainly because of its much lower profile. This is very thin skin. You can get the needle underneath it. It has a much better spatial resolution. And for the posterior tibial artery, please hit the nose and not the eyeballs. There's paired veins associated with it. You should also not be shy of using the transverse technique, which I see a lot of people omit when they use ultrasound guided imaging, because you can actually even see with high spatial resolution probes, you can see the bevel of your needle and even know which way Mustafa and Baha and Saab do a lot of even imaging for their total occlusion crossings with ultrasound. Dorsalis, pedis, and AT axis, the limb is left in a straight position with a little dorsiflexion of your foot. You need to bend the knee and laterally rotate it for your posterior tibial when you're doing this antegrade access, but that's a whole nother talk. And if you use radiographic guided imaging, you need to separate the tibia and the fibia completely so that you can go in between them. And you need to realize you have to do orthogonal views to be parallel in one view and perpendicular in the other with radiographic guided imaging for angiographic guided access. Hemostatic options, you can use manual compression. You can use antegrade balloon occlusions during or after your retrograde crossing and wire capture and flipping it back to the antegrade. But my favorite is a radial access hemostatic device placed on the foot. So for CLTI interventions, I think there are almost zero contraindications because of the indication of what you're doing it for. Most limbs, it's not perfect. It's not like most beds we perform angioplasty in. Success rates, but they're above 90%. And I think retrograde pedal access is for increasing its patency rate is the new kid on the block. Thank you very much.
Thank you, Doctor.